to etiology, identification, and treatment of chronic pain from chronic muscle spasm. I have proposed the ischemic model of chronic muscle spasm. In short, muscles that are subjected to overuse develop an overuse injury. Not given time to recover, they run out of energy, the very energy that is needed for the muscle to relax. Actually, it takes more energy for the muscle to relax than to contract. Additionally, the developing prolonged contractions impairs the microcirculation of the muscle, eventually leading to a loss of mitochondria and muscle tissue. Over the short haul, the impaired circulation sets off arrhythmias in the muscle, similar to what happens with the heart. The arrhythmia then represents the linchpin that keeps the muscle in chronic. Identification of chronic muscle spasm is achieved by use of an EMG device, which essentially is an EKG for muscle. Muscles in chronic spasm demonstrate spontaneous electrical activity, or SEA. Think of this as an arrhythmia resulting from the prolonged ischemic state. Much like we see in the heart, an ongoing arrhythmia like atrial fibrillation continues to cause contraction. The left atrium and atrial fibrillation can be seen to constantly quiver, seen in this echocardiogram. This is the left atrium, and here is the ongoing contracture. In a similar fashion, skeletal muscle with ongoing SEA continues to contract with ongoing depletion of energy. My research into chronic muscle spasm revealed that muscle in chronic spasm was electrically active. I continue to find it curious that of the hundreds of EMG studies that I continue to review in my retirement job as a medical underwriter, there was never mention of spontaneous electrical activity that is found in muscles in chronic spasm. About 15 years ago, I bought an EMG device and started to use Botox to treat chronic muscle spasm in patients and family members. The clinical use of Botox was nothing new, but the use of an EMG device to identify the areas to treat was just beginning to be used. Various treatments of chronic muscle spasm need to find ways to restore normal blood supply and quiet arrhythmias. One of the more recently accepted treatments is dry needling. While the actual mechanism of dry needling is not fully understood, it disturbs the ongoing electrical activity, at least partially, and may enhance the blood supply. A treatment that I have developed works directly by blocking the SCA with a sustained effect for 2 to 3 months. The muscle blood supply is restored, and the muscle can recover from whatever damage it has sustained from a prolonged impairment of its blood supply. What is most exciting about the procedure is the immediate and sustained relief of pain that accompanies the resolution of the chronic muscle spasm. The question, what is the cause of SEA, had never been clearly answered. In the world of myofascial release, it is generally accepted that SEA is only seen in the end plate, or by other authors that it is simply end plate noise without clinical significance. The very large areas of muscle SEA that can be found with EMG examination of muscles in chronic spasm speaks against the concept that SEA is only at the end plate or that it is simply end plate noise. Current concepts now include debate over intrafusal and extrafusal spontaneous electrical activity, and is clearly beyond the scope of this talk and my knowledge. Looking for understanding of the etiology of chronic muscle spasm and SCA, I borrowed from my knowledge of cardiac muscle. It is known that diastolic blood flow in the coronaries is greater than systolic blood flow. The presumptive mechanism is compression by myocardial contraction on the capillary bed, restricting blood flow. Unpublished work that I had done during my cardiology fellowship demonstrated that progressive suppression of the force of contraction with progressive doses of beta blocker medications led to a reversal of flow dynamics, wherein the predominant flow was systolic. This work indicates that the severity of contraction or spasm determines the degree of restriction of blood flow. It is known that cardiac muscle, when ischemic, can develop arrhythmias such as ventricular fibrillation. Ischemic myocardium has been shown to have membrane abnormalities affecting the sodium, potassium, and calcium channels that are energy dependent. It is also known that the chronic myocardial ischemia leads to the development of what is called hibernating myocardium. Subcellular elements are depleted, and upon restoration of blood flow, many months are required to repair and have return of normal function. The treatment I have developed makes use of an FDA-approved medication in an off-label use. The medication is phenoxybenzamine. It currently has limited use in humans, but is still used in veterinary medicine and is thus available to be sterilely compounded. Phenoxybenzamine forms a covalent bond on the muscles alpha adrenergic receptor. The net effect is a cessation of the SCA. It takes months for the muscle to replace the receptors, and this explains the prolonged duration of action of the drug. The treatment also makes use of lidocaine and dexamethasone. The lidocaine acts immediately by its antiarrhythmic properties to stabilize the electrical activity and override the sensation of pain that would be caused by injection of the phenoxybenzamine alone. The duration of action of lidocaine is just enough to cover the delay in the onset of action of the phenoxybenzamine, which is about 1 hour. The dexamethasone helps to minimize the irritant effect of phenoxybenzamine. The procedure itself is performed using an EMG device to locate the muscle demonstrating SCA. Very small aliquots of the injectate are given through the EMG needle throughout the muscle until all SCA is resolved. This short, clearly non-professional video shows the SCA in a tensor fasciculata muscle. The patient had IT band syndrome, secondary to chronic spasm of the tensor fasciculata muscle. When I was able to locate the muscle, there was clear and obvious SCA in a patient at rest. With multiple small injections of phenoxybenzamine, lidocaine, dexamethasone solution, the SCA is eliminated. This is initially the result of lidocaine because of its antiarrhythmic property. The long-term result is that of the phenoxybenzamine that takes about 1 hour to take hold. I propose that SCA is simply the result of chronic ischemia resulting from periods of acquired muscle spasm left untreated. This can result in membrane instability as one cause of SCA. Phenoxybenzamine forms a covalent bond on the postsynaptic alpha adrenergic receptor. It is a functional duration of action of 2 to 3 months while the muscle is developing replacement receptors. This 2 to 3 month duration of action appears to be sufficient for the muscle to mostly recover. Getting back to the story behind the development of this procedure, I first tried to inject myself with phenoxybenzamine and found it to be quite painful. I added lidocaine to the mix to relieve pain. This turned out to be a markedly fortuitous occurrence as lidocaine immediately resolves the SCA, allowing mapping of the areas successfully treated, which facilitates the identification of areas yet needing to be treated. The dexamethasone mitigated the short-term and medium-term discomfort from the procedure. It was also shown that it did not matter how long the muscle had been in chronic spasm, that is 3 months or 20 years. The procedure is equally effective. In my experience, the patient I treated with the longest lasting spasm was 27 years. A full-blown clinical trial has yet to be done, but I have collected information that supports its utility. I did a survey of my patient and assembled it into a spreadsheet that was able to be correlated. The result was supportive of a positive outcome to the 0.01 p-value level. The data to support the effectiveness of the CMECD procedure was initially assembled in preparation of my second article, which was treatment of chronic pain secondary to chronic muscle spasm with the CMECD procedure. A patient survey from several years before was put into a spreadsheet, and thanks to the volunteer efforts of Diego Guidolin, Department of Neuroscience, University of Padua, Italy, it was demonstrated effective beyond the 0.01 p level. The first slide shows the entire data set. In a somewhat less busy slide, with half the data per slide, it can be seen that a relatively large number of patients had complete relief of pain lasting greater than 3 months, which length of time was used as a measure of long-term success. Virtually none of those patients ever had to return for additional treatment unless they found a way to recreate the obvious injury that had been responsible for the initial development of chronic muscle spasm. As noted before, the data demonstrated with statistical significance that the time that the muscle was in spasm did not matter regarding the effectiveness of the procedure. I followed a significant number of these patients as their cardiologist and would have been told that the pain had recurred. As can be seen in the second half of the data, a relatively small number of patients had no relief. Causes for that were unclear, but 2 individuals ultimately required back surgery and a few others had not gotten relief from epidural injections or any other modality. I did not provide any pain medication for these treated patients. It is also notable that a significant number of patients were able to discontinue or at least decrease opioids and other pain medication. As is generally the case, no procedure is perfect without unwanted side effects. But the only significant side effect of this procedure is local site soreness that generally lasts 3 to 4 days. The known pharmacologic effect is to lower blood pressure, and that needs to be taken into account for use on patients taking antihypertensive medications. The pharmacologic duration of action is about 1.5 days. Decreasing antihypertensive medications may warrant consideration for 1 day, especially for patients with tight control of their blood pressure. Overall, I have treated at least 30 different muscles in well over 200 patients. Virtually every muscle group can be responsible for chronic pain, and have not yet found one that cannot be treated with the CMECD procedure. However, treatment of the anterior migraines by injecting the temporalis muscle is discouraged because of the inflammatory effect with tissue swelling that is not attractive. On the other hand, posterior migraine can be successfully treated with injection of the posterior cervical strap muscles right up to the skull. I have found a very valuable work that I have depended upon for years. The Trigger Point Therapy workbook by Clara Davies and Amber Davies is extremely useful in getting a handle on which muscles are the likely source of pain. For muscles that are not yet in full chronic spasm, the techniques described are likely to help resolve muscle spasm. One of the lessons learned is a phenomenon my wife coined, the hierarchy of pain. I first came across this when, after having injected the patient's right arm, he stated that now his left arm hurt. What I learned is that with resolution of the primary pain, the secondary pain comes to light. This phenomenon is critical to take into consideration and follow up post-procedure, as clear identification of pain sites is critical in assessing the success of results. I have maintained a website, CMECD.info, which contains all the publications, a dozen abstracts, and 2 articles that I've written. I also published a book, Chronic Muscle Spasm and Pain, Etiology, Identification, and Treatment of Chronic Muscle Spasm and Resultant Chronic Pain. I get no royalties from the book to keep the price down. I trademarked the procedure as CMECD, which is an acronym for Coletti Method EMG-guided chemodenervation. The procedure was not patented to make sure of its availability. The trademarking was done to ensure the process was clearly identified. Of the 2 papers I published, the most notable was the ischemic model of chronic muscle spasm. It was that article and not my book that attracted attention and why I was invited to speak to you. For what it is worth, the book is available on Amazon and other retailers. The 2 articles taken together summarize both the theory and practice of my findings. The initial article, The Ischemic Model of Chronic Muscle Spasm, was published in the European Journal of Translational Myology. The second article is Treatment of Chronic Muscle Spasm-Induced Chronic Pain Treated with the CMECD Procedure, was published in the International Journal of Physical Medicine and Rehabilitation. The second article had been of interest to half a dozen journals for publication, but I wanted the primary reader of the article to have access to EMG devices. Phenoxybenzamine compounded with dexamethasone is available from what was to me a local pharmacy when I lived in New Jersey that happened to be a sterile compounding pharmacy by the name of Miller's Pharmacy in Wyckoff, New Jersey. They can ship to anywhere in the United States, overnight on ice. The concentration of phenoxybenzamine is 5 milligrams per ml, and dexamethasone sodium is 1.5 milligrams per ml. On site, it is diluted at a 1-to-1 ratio with 2% lidocaine at the time of injection. I recently came across lidocaine that was not at the usual pH of 3 that is required for phenoxybenzamine to stay in solution. Instead, it came out of solution with the addition of lidocaine and went into suspension. It is unclear if the proper chemical reaction would occur with the drug in suspension. With the new low dose, lidocaine is added at a 3-to-1 ratio. To begin with, you will need an EMG device. Handheld devices are entirely adequate. I prefer those with a screen rather than those that are sound only, which are of a lower price. The cost per patient from Miller's Pharmacy is currently $60 per patient per vial, and the cost of an EMG injection needle is $18. For those outside the United States, phenoxybenzamine is available to any licensed pharmacy in the world from a company in Texas, USA, by the name of PCCA, and their contact email is clientcare@pccarx.com. They will ship worldwide, and you then need a sterile compounding pharmacy to add the dexamethasone or add it yourself and add the lidocaine at the time of treatment. What should be of most importance to this audience is that this is a procedure that can be undertaken now by any medical practitioner already doing any kind of muscular injection without the need for specific training beyond what was just seen in the prior procedural video. As mentioned earlier, this procedure is making use of an FDA-approved drug in an off-label mode. The FDA requires 3 things for off-label use. The patient needs to be told it is an off-label use. The clinical person doing the procedure needs to know its mechanism of action as best is known and must keep records of any complications. In many fields of medicine, such as my own in interventional cardiology, drugs are used off-label routinely. The FDA currently requires the compounded medication to be made up for a specific patient and to be within 4 days of manufacture or 3 months if frozen. I have typically frozen the vials when they arrive and take heed of the 4-day rule when they are thawed out. This allows me to treat other muscles on the same individual weeks after the initial encounter and minimize the cost. The EMG injection needle comes in length from 1 to 3 inches. This is a 3-inch needle that I routinely use. I find that one can minimize skin punctures with a longer needle while exploring and treating the muscle. This slide demonstrates an EMG of normal muscle. Inserting an EMG needle into a muscle will result in a variety of insertional activity electrical signals. The term increased insertional activity is an indication of some degree of muscle pathology. It can be seen in muscles in chronic spasm and in muscles that are in a borderline state of chronic spasm. The procedure dry needling, essentially the same procedure as EMG evaluation, setting off runs of increased insertional activity, appears to be therapeutic, likely because of the neutralization of electrical instability. This video is a classic example of increased insertional activity. In muscles in true chronic spasm, the increased insertional activity does not resolve the spasm. Injection through the muscle in a chronic spasm with the phenoxybenzamine, lidocaine, dexamethasone cocktail requires only a single injection for what is essentially a permanent resolution of spasm. Dexamethasone was added to the cocktail as phenoxybenzamine is a tissue irritant, and the dexamethasone helps resolve the inflammatory response, at least for a few days. Discomfort from the injection can last for up to a week, but typically is 3 to 4 days. This video again demonstrates a typical SEA with a chaotic appearance. This next video demonstrates the effect of a CMECD injection as seen on EMG tracings with full suppression of the previously seen SEA. There's a section in my book and also found on the CMECD.info website entitled Step by Step. In that section, I present all the details needed to begin using the procedure, as well as insights and questions for each of the major muscle locations. As I noted earlier, I'm now using a dose of phenoxybenzamine half strength than what I had used in the past. Hopefully, it will be shown that this dose is better tolerated and equally effective. The question you should be asking is why all of this has not been obvious to many in the past. So much has been done to treat chronic pain and chronic muscle spasm, yet the simple finding of diffuse SEA is not common knowledge in the medical world. As it turns out, there has been a lot of research about trigger points with a fair amount of conflict as to what is the origination of the SEA. With all the highly technical approach, the broad findings were overlooked. The use of phenoxybenzamine was attempted in 2 trials with EMG guidance without success. This is most likely due in part to the very high doses utilized that were up to 10 times my historic dose and 20 times my current dose. Tissue irritation and even tissue damage was noted. Diffuse spreading of the injectate was also not utilized. I was fortunate to have a local compounding pharmacy suggest a dose based on a reference somewhere in the pharmacological literature that I have not successfully been able to trace. The primary reason I'm presenting my findings to you today is to provide you the opportunity given to few to relieve chronic pain without the use of opioid medication with a simple and inexpensive procedure that needs to be done a single time for long-term relief. Some of my patients are able to discontinue their opioid medications altogether or at least lessen their use as noted in the patient survey shown before. I provided no pain medication to any of these patients. While it would be preferred to have a large clinical trial with substantiated results, the use of an approved FDA drug with few known adverse effects to use in place of opioids should be relatively easy to defend. I hope this information provided in this presentation will increase your chance that you will undertake the procedure, gain the satisfaction of relieving chronic pain of your patients, not to mention the benefit you have provided to your patients. Thank you for your time and attention.